Well, good evening, and thank you for joining us. I'm Robin Oldfield, Associate Vice President of Audit, Risk and Compliance and Chief Risk Officer. And I'm pleased to welcome Dr. Mary Buchwalder, UD's Director of the Student Health Center, and two members of the university's medical panel who have been involved in helping shape the university's response to the COVID-19 pandemic. Dr. Buchwalder, Dr. Steve Burdette, and Dr. Roberto Colon have brought many years of medical expertise to help guide the university's response to the pandemic, including safety protocols, our testing program, quarantining, isolating, treatment. On behalf of the university, I want to thank them for their generosity in sharing their time and professional expertise with the university. We recently launched the Build Immunity in Our Community Challenge in order to have at least 70% of our entire campus community vaccinated by July 1st. The level of immunity in our community will inform our approach to restrictions and requirements, especially those most important to our employees, students, and families. We all know that we are looking forward to a year with more in-person learning, community building activities, and social opportunities. We compiled a list and we received from students, faculty, staff, and families, and we will start with those. If we have time, please feel free to put your questions in the Q&A function, and we will try to get to those at the end of the program. While the focus of this town hall is on the medical questions related to the COVID-19 vaccine, we did receive many non-medical questions related to the university's policies and protocols. As you know, conditions are changing rapidly, and we will continue to monitor on campus and surrounding community as we evaluate our options for helping to reduce the risk on campus to the campus community. But we will try to get some of those questions as well at the end. Now, I would like to ask our panel to go ahead and introduce themselves. I'll start with Dr. Mary Buchwalder.
Good evening, everyone. My name is Mary Buchwalder. I am a board-certified family physician and the medical director of the University of Dayton Student Health Center. Steve?
All righty. Hi there. I'm Steve Burdette. I'm an infectious disease physician. I work here at Miami Valley Hospital, and I am also the medical director of antimicrobial stewardship and infection prevention here at MVH. So, Dr. Colon.
Try that again. Hi, good evening. My name is Roberto Colon. I am a board certified internist. I'm also the chief medical officer for Miami Valley Hospital and the vice president for quality and safety for Premier. Thank you.
Well, thank you. So we'll jump right into the questions. The first one is for you, Dr. Burdette. What impact have the vaccines made on hospitalizations? Cases are down. What types of hospitalizations are you seeing, and what does this indicate about the effectiveness of the vaccines on infection and transmission?
Yeah, so the vaccine has made a huge difference. In December, between December, which is kind of where we hit our highest peak toward the end, first part of January, to now, we are down over 90% on our inpatient service. It has made a huge difference. And there was a lot of things, obviously, you know, a lot of people had COVID last fall over the winter time. But if you track our numbers from the time that the vaccine was started to be given in nursing facilities to healthcare workers right around the end of December 21st, 22nd, something along those lines, you know, you can track the decrease in our census. I mean, from just tons of patients on multiple units to now just a handful of patients. We don't see the nursing home patients. I mean, we used to get multiple nursing home patients every day into our COVID unit. And now we almost never see them. You know, we'll talk a little bit later about, you know, the efficacy of the vaccine and some of the numbers around that. But the biggest thing, I have no doubt, that has impacted our census in our inpatient unit has been vaccination, not just amongst the patients, but also amongst the staff.
Great, thank you. I have another one for you. Can you address some of the concerns we have heard about the vaccines? Some people believe that they are considered experimental. Can you talk a little bit about the emergency use authorization process and how the vaccines have been tested and what it will take to get FDA approval and when we expect them to be approved?
Yeah, so this has been a question that I deal with almost every day for the last, really 5 to 6 months. So the emergency use authorization, these vaccines are still studied. They are well studied. The classic medical device, the medication research that we do goes through a phase 1 study, which is where you're giving it to around 100 or so patients to look for safety. And then you expand to a phase 2, which will be hundreds of patients where you're looking at efficacy. And then you go to phase 3 studies, which will be thousands of patients to look for efficacy and safety in a much larger volume. Pfizer, Moderna, J&J, the Janssen vaccine have all gone through phase 1, phase 2, and phase 3 studies. In fact, if you compare it, many of the parents, maybe you've had a shingles vaccine. The shingles vaccine was approved based on a study of 7,500 or so patients that got the vaccine and 7,500 or so who received a placebo, 15,000 patients. Pfizer, for their study, had 30,000 patients. Moderna had 30,000 patients. And I apologize, I don't know the J&J study right off the top of my head, but the number of patients was immense. Well, what's the difference? Well, there was a huge demand. There was waiting lines to get enrolled into the COVID vaccine studies. So normally we have to beg, we have to plead, we have to give goodies to get people to enroll in research studies, whatever we got to do to get people enrolled. And with this, they were coming to us. They were coming to the sites to get enrolled. So instead of taking years to enroll 15,000 people, it only took months to get 30,000 people enrolled in the studies. So the difference with the emergency use authorization is, one, it moves the entire packet of paperwork to the very top of the list. Normally, if I turn in a drug today to get approved for an FDA or to be evaluated by the FDA, they're not going to look at it for 9 months to a year. When they do an EUA, it moves it to the top. And the one area that they do adjust for this is it's 2 months worth of safety data that is required. Pfizer last week turned in their application for full FDA approval for their vaccine. Moderna's is expected to follow behind shortly. And with that, they have to turn in 6-month data. So they need a longer set of data for the full authorization. And that's really the only adjustment that is used with these vaccines. Again, the shingles vaccine, 15,000 people. This one, 30,000. And if you combine the Pfizer and Moderna, and one of the reasons I'm so confident in these vaccines is they're very similar vaccines, just very subtle differences. And the data is almost identical. And so that gives me even more confidence in that. And the last thing is, yes, these were emergency use authorizations, so they only had the 2-month data. I can't tell you a single other therapeutic that we have done in the United States where we have given it now 277 million doses of vaccine have been given in the United States. 125 million Americans are fully vaccinated. Everybody who gets enrolled in the vaccine or receives a vaccine is enrolled. We have to turn in adverse events. There is websites where we have to enter the data for the FDA, other accrediting bodies to review. And the amount of data that we have on the COVID vaccination blows any other therapeutic out of the water. There's just nothing else. Luckily, there's no antibiotic that we have to give to 277 million people. There's no cholesterol drug that we give to 277 million people, but we vaccinated that many. We have robust monitoring for the side effects, for the adverse reactions. Are there occasional ones? There are. But the data that we now have beyond, from this rollout of this vaccine makes me very confident in the safety and efficacy of it.
Wow, thank you. Very compelling data. Dr. Buchwalder, I have a question for you. Why is there such a push to get young people vaccinated? Many believe that young people are at low risk for COVID-19 and may feel that they are at greater danger from the effects of the vaccine.
Thanks, Robin. I appreciate you asking. A lot of people note that young people are at low risk of dying from COVID-19 infection, but they're definitely at risk of getting infected. And if they get infected, they can pass the virus on to others. people who are more vulnerable, who may not have been vaccinated, including family members, potentially people who have a medical condition that they can't get vaccinated. So they risk infecting others if they're not vaccinated. Another really important point is that if we have a reservoir of unvaccinated people, whatever age, the virus continues to circulate. And as the virus circulates, it has opportunities to mutate and create new variants. And one of the big concerns is that as long as the virus is still pretty actively circulating, that we can see deadly new variants and have to react to those or see an upsurge in infections again. So the more people receive vaccinations, the less the transmission, the less the virus can circulate, and the fewer chances we have to create new variants. And the other thing with young folks is, while they may not die from COVID, we've seen lots of instances worldwide where young people can get pretty serious long-term effects. Chronic lung issues, heart issues, brain fog, and certainly those can be pretty devastating in someone who has all their years ahead of them. The other thing, the comment that young adults at low risk of dying, I'd remind everyone, even though death is rare in young people from COVID, even one death in a young person, as we had last fall, is so very tragic. And now with the vaccines, it is entirely preventable.
Thanks, Dr. Buchwalder. Dr. Colon, we've had several questions come in regarding immunity, so I'm going to read several of them to you. Why do you recommend getting a vaccine if somebody has already had COVID-19? Doesn't having COVID-19 give you immunity? Why should I get the vaccine if I'm already immune naturally? And finally, do vaccines offer better protection against the variants?
Great questions, and this is actually something that comes up a lot. Unfortunately, we've actually accumulated a fairly robust amount of data that has helped us be able to answer that. And bluntly, these vaccines do appear to do a better job about protecting us from more variants for longer than getting an infection and developing so-called natural immunity, as we normally would recover from an infection. A lot of that has to do with the fact that these vaccines produce a predictable response that is higher than what we are receiving with our natural immunity. In many cases, or not in many, but in the majority of cases, we're seeing immunity responses where our body, after a vaccine, can produce 10 times the amount of antibodies that we are generating from an infection. And a lot of that has to do with the fact that when we get infected from another person, the size of our immune response to that initial infection largely depends on how much we were receiving as far as the inoculum, the amount of the virus, how well it propagated in our body, our viral load, and their own individual body response. When we give somebody a dose of a vaccine, it is a premix, everybody gets the same amount. And the only thing that can have a bit of variability one way or the other would be if somebody has an immunocompromising condition, severe immune deficiency. But beyond that, it allows us to be able to mount a better response. When we get COVID, our antibodies gradually drop, and we're not seeing that those antibodies last very long, particularly if we had milder symptoms. Giving the immunization to those people actually creates that booster effect and brings up our immunity level back up to give us that longer lasting protection. Lastly, we're seeing that those vaccines appear to be giving us more protection from the variants than when we are getting a natural infection. And that may have to do with our response to the spike protein, which is what we are really generating with these vaccines. What we're interestingly also seeing is that these vaccines appear to be helping many of the people who develop the so-called long COVID syndrome to recover from that. So that's another benefit for people that are having some of those chronic symptoms as another way of being able to get over that chronic illness related to COVID.
Very informative, thank you. Dr. Buchwalder, this next question is, somewhat repetitive, and you might just want to piggyback off of Dr. Colon here. Does the 70% goal that the university for the university's vaccine challenge take into account those individuals who have an immune because they already have had the virus? If not, why not? Isn't this natural immunity from previously having the virus better than a vaccine?
Well, I appreciate Rob's comments because he really made a good case for why people who've had natural infection should still get vaccinated. And so when the university was looking at what goal do we set for our challenge, we are hoping to have 70% of our campus community vaccinated. So if they've had natural infection, that vaccine can boost their immune system's response and protect them more. Should they, in the really tiny chance that they are exposed and actually get an infection, oftentimes very minimal symptoms, that's very unlikely, but they're also, those who are vaccinated are then less likely to transmit too. So transmission within our congregate living setting and just our community in general, again, yes, we want everyone, that 70% is 70% vaccinated.
Great, thank you. Dr. Colon, I have another one for you. We received several questions about how the vaccines affect your DNA. Do they interfere with it or change it? What does the mRNA vaccine do, and how is it different from other vaccines? And another frequent question is, do the currently available vaccines have any effect on fertility for women and men, especially those who are now college-aged?
This is a question I get very, very often. We've been dealing with this from the beginning, and I'm going to start with a little bit of the science and virology. The way that RNA viruses, coronaviruses are RNA viruses, so are the viruses that give you the common cold and influenza. The way that they infect the body, when they get in through our nasal mucosa, through our respiratory system, they actually have these proteins on top of the cells. These are the spike proteins for a coronavirus that actually stick to the cells and are what allows the cell to pull the virus inside the cell. The virus then releases all of its genetic material, all the blueprints for all of the pieces that make up a virus, including the RNA. It then makes our own cells replicate the virus and put all the pieces together and spit out a whole bunch of viruses. And that's what creates the virus that gets worse in the body after we get some of that infection. That's how a virus normally does that. It never enters, that RNA does not enter our nucleus where our DNA lives. It doesn't alter it. What we have done with these mRNA vaccines, and by we, I mean the geniuses that actually created these vaccines, is that they have taken that long RNA sequence from that virus and took the tiny piece that encodes for those spike proteins inside, on the outside of the virus. So they just took that tiny little piece of the blueprint and they put it inside of a little fat molecule. They then put that into a vaccine. When that gets injected into our arm and our body absorbs it, those fat molecules actually get brought in to the cell. And we have fat molecules floating around after many of the meals that we have. When the fat molecule comes in, it dissolves and it releases that tiny little piece of RNA that only encodes for the spike protein. It then uses the same mechanism to have the body create that protein for that spike that gets put on top of the cell that induces our own body to recognize that spike protein as being abnormal. And that viral response or that immunity response is what gets multiplied, and it helps us recognize that same spike protein when we see it later on with an infection. What these mRNA viruses vaccines have done is created this science where we have this tiny little segment without having to have any other viral vector. Many of the other vaccines used either a weakened virus as a vector or a likened virus that was empty inside to put in DNA pieces. This is just a little lipid molecule with that tiny piece of information blueprint that comes into our body. And it replicates the same way as our normal viral infection would have, without entering the nucleus, without touching the DNA in any way, shape, or form. The other interesting thing about these vaccines, they've actually been studied for decades. We have been using these in studies to treat cancer for a very long time, and they've been pretty successful in getting that information and that body of data to be able to move to utilize them for the management of lung cancer. They have, through that data, never been shown to alter DNA or lead to any of those mutations because they don't touch the DNA. It does not cross into the nucleus. So it is very safe. It does not alter that. The other thing that we hear a lot is this concern about fertility. And we've been able to actually figure out where this came from. Earlier, after the vaccines were announced, there was a report that came out of Europe that claimed that there were amino acids side by side that were very closely resembling a chain in the placental protein. So what they claimed is that this spike protein had amino acids in a row that made it identical to what we see in placental tissue. There were 4 amino acids in a row. In order for a protein chain of hundreds of amino acids to even be considered closely mimicking another, you need to have at least 8 to 17 in a row for you to start having that worry. So we didn't even meet anywhere near the definition for the number of amino acids that you have to have in a row for similarity. But here's the catch. Because we use the same genetic material that is in the virus, if this were a true phenomena, every time somebody got infected with COVID, because it's the same spike protein, they would also be susceptible to immunity, to infertility, which does not at all occur. We haven't observed that. What we have observed is that pregnant women who do get COVID are more likely to have fetal loss or fetal complications. We also saw that during the studies where they were evaluating the vaccines, several women became pregnant while they were part of the vaccine arm without a complication. There was one woman that became pregnant and had a miscarriage on the placebo arm, not the arm that actually received the vaccine. So these are actually proven to be safe. They do not alter the DNA and they do not interfere with fertility.
Oh, that was very informative. Thank you. Dr. Buchwalder, I have one for you. Is it true that the vaccine was developed using aborted fetal cells? If so, how does this align with Catholic and Marianist values?
Thanks, Robin. Yeah, when the vaccines were starting to become available here in the U.S., I met with Father Jim Fitz, our rector, and Crystal Sullivan of campus ministry to discuss the ethical concerns. As folks on this call certainly know, the church emphasizes that abortion is a grave moral danger. The U.S. Conference of Catholic Bishops discussed the moral considerations involving COVID-19 vaccines. They note that the 2 mRNA vaccines, the Pfizer and Moderna, did use cells cloned in a laboratory from an abortion that happened several decades ago for the research for their vaccine. Johnson & Johnson vaccine, or Janssen, similarly used cells cloned in a laboratory from a remote abortion for the research and production of their vaccine. None of the COVID-19 vaccines currently authorized or in the US or anywhere use cells taken directly from the body of an aborted child. The bishops go on to say, I've got some quotes, "We cannot omit fulfilling serious obligations such as the prevention of deadly infection and the spread of contagion among those who are vulnerable just to avoid the appearance of scandal. In addition, receiving the COVID-19 vaccine ought to be understood as an act of charity toward the other members of our community. In this way, being vaccinated safely against COVID-19 should be considered an act of love of our neighbor and part of our moral responsibility for the common good." And I want to point out the footnote to that comment. The bishops note, "We should keep in mind that some people cannot themselves be vaccinated, They must rely on the rest of the communities becoming immune through vaccination so that the disease does not travel through the community and infect them. That being said, the bishops do reemphasize not to let taking the COVID-19 vaccine diminish our sense of urgency of opposing the evil of abortion. So they're looking at both sides of the vaccination, that this is the remote connection to an abortion that occurred previously, and that ideally we could have vaccines that don't have that, but currently we don't. And the seriousness of the threat of COVID and the responsibility to each other to try to get rid of this scourge on our land. So their conclusion, the world is currently facing a health crisis. In December, at this point, the number of deaths was around 300,000 and 1.5 million worldwide back then. Given the urgency of the crisis, the lack of available alternative vaccines, and the fact that the connection between an abortion that occurred decades ago and receiving a vaccine produced today is remote, inoculation with the new COVID-19 vaccines in these circumstances can be morally justified.
Thank you, Mary. Dr. Burdette, I have a question for you. How do you explain the breakthrough cases like the New York Yankees? How can the vaccine be considered highly effective if these breakthrough cases occur? Does this suggest that people who have been vaccinated should be tested?
Yeah, so I don't want to offend any Yankees fans, so I will not make fun of the Yankees during this presentation. So when you look at vaccine efficacy, we get the flu shots. Many of us get the flu shot every year, and it's 30 or 40% effective. The shingles vaccine, which I've mentioned now several times, is 90% effective. And when Pfizer and Moderna released their data, it was 95% effective. So let's do the math that if it's 95% effective and we've given it to 125 million Americans have completed their series, that would still put us at about 6,250,000 cases that would still get COVID, because there is no perfect vaccine. There is no medicine that works for everybody. Again, we have cancer patients, we have transplant patients, we have patients that are elderly whose vaccines their immune system doesn't respond as well. So there is nothing that is 100%. What we're seeing clinically with the Pfizer Moderna vaccine specifically, because we have the most experience with those, is an efficacy that's coming in right around 99.999%, okay? So at that rate, we're still gonna have 125,000 people who have been vaccinated who are gonna come down with COVID, just based on purely math, okay? But I can tell you clinically, I deal with this every day, 7 days a week. What we see is, number one, when you've had COVID, you can shed dead, inactive, non-contagious virus for 6-7 months sometimes. The longest we've seen is just right around 6 months, okay? So you could have had COVID 2 months before your vaccine, or as we talked about, Dr. Buchwalder talked about earlier, we still vaccinate folks that have had previous infection. Well, I test you 3-4 months after after you've been infected, you can test positive for COVID. And we see that every day. We go talk to the patients, they're coming in for something, they test positive, they've had the vaccine, they get all confused, and we go talk to them, and they had COVID in February, and they're just testing positive for dead virus. So that's number one. Number two is, with the testing that we do, the FDA, when they released these assays, did not want to miss COVID. So the sensitivities are set extremely low or extremely high. I mean, they just don't want to miss anything. So we have people that are probably false positives. We have people, again, that had COVID many, many months ago that still test positive. Even in folks that have not had it, they've had 2 or 3 negative tests, and then all of a sudden will test positive. It's just because every once in a while you release virus. We've been seeing that in kids with a virus called RSV for decades. This is a known entity. This is not something new with COVID. But the last thing to tell you about is, again, your vaccine, you can still be exposed to COVID. It's just that your body is going to deal with the virus. And when your body deals with the virus before you get sick, it's going to kill the virus and it's going to release dead virus. So if any of you have traveled to a third world country, to somewhere where you have to take malaria prophylaxis, you take the medicine to prevent your malaria. Well, you get malaria. It's just that the medicine kills the malaria before it causes you to get sick. So in this case, if you're vaccinated and somebody comes down with COVID and you're exposed, you could test positive for the virus, but you're not going to get sick 99.9999% of the time because your immune system is there. So the whole testing of COVID is a very challenging thing. That's why we're decreasing when we can. When we test, we try not to test people that are vaccinated who are asymptomatic because we're going to come across these situations. But don't read too much into these cases of, oh, so-and-so got vaccinated and they still got COVID. Well, again, occasionally we're going to see that. I've got one in the hospital now, a very elderly person who is sick from COVID after the vaccine. Well, I'm sorry, that is going to happen. But for a majority of folks, the vaccine is going to keep them safe.
Thank you. Dr. Buchwalder, why is the university's vaccine goal 70% and not 85% as some articles have suggested? If you still have 30% of the campus community unvaccinated, how are faculty, students, and staff expected to feel safe in the classroom?
Thanks, Robin. Yeah, we've discussed this with our medical advisory panel. We've talked to public health, and really, this is a new virus. We don't know what the magic number is of percent of people vaccinated to help reduce transmission enough to protect the whole community. One of the things as Director of Student Health, we know that with the regular health requirements like measles, mumps, rubella vaccine, most of the students early on will report their health requirements, but there's always a group beyond who report initially who've had their vaccine but haven't reported it. So if we're looking for 70% documentation, likely there will be a group of procrastinators who I know people who would do that, who have been vaccinated, who haven't yet submitted that documentation. So in our discussions, we felt like 70% would be a place where we would have confidence that our community is well protected. The other consideration with that is just that as a new virus, at some point you have enough people vaccinated that the virus doesn't circulate well. We talk about herd immunity. Again, no magic number, and this is a new virus. But when not only the people vaccinated are protected, but if the virus is not circulating as much, those who are not or cannot be vaccinated are also protected. You see the numbers really drop off. And I'm very encouraged by the changes we're seeing in cases, hospitalizations. I think it's all we're seeing good immunity in our broad community of the United States. So.
Thank you, Dr. Buchwalder. Yes, this is very encouraging to hear that the efficacy and how it's really starting to curtail the spread of virus. I have another question for you. Should I be concerned about returning to work or to the classroom in person in the fall if I've been vaccinated and I have a good immune system?
Yeah, so if you've received the vaccine, as Steve and Rob have both alluded to, the vaccine is incredibly infected. It's late, sorry guys. Incredibly effective. And if you've been vaccinated and you've got a normal immune response, you may be exposed, but your chance of getting an infection at all is very small. Your chance of getting an infection that will cause you to be hospitalized or die is incredibly remote. So if you've been vaccinated, being in person again with other people on campus, sitting in classrooms, dining, with others should be very, very safe. I mean, we don't worry about getting measles when we go out. And if we've been vaccinated, the vaccine is extremely protective. And we don't worry about polio anymore. I mean, those things are diseases that vaccines have almost fully. The measles cases we've seen in recent years have been pockets of unvaccinated groups that it spreads very readily. So with COVID, it looks like we're, again, you've been vaccinated, your protection level is great. You should be able to go on with life without having to worry about serious illness anyway.
Dr. Burdette, I have a question for you. If I'm vaccinated and I'm indoors with an unvaccinated person, should I wear my mask? Should I ask them to put their mask on and to practice physical distancing?
Yeah, so I'm going to answer that in 1 second. I actually wanted to go back and clarify two things that I had said that I probably said this morning that I need to clarify. Number one, our inpatients right now that are admitted to the hospital are nearly, I want to be very clear with this, are almost all unvaccinated. Okay. Some of them, even though they're sick, they don't want to get the vaccine, even when they recover. And so we have seen a major shift. I said we don't see nursing home patients anymore. We rarely do. But what we continue to see is people, especially with risk factors, medical problems, obesity, poorly controlled diabetes, who are not vaccinated, who come into our COVID unit. So again, going back to how well the vaccine works. Number two, for full disclosure, I have kids. My 18-year-old is vaccinated with Pfizer. My 20-year-old is vaccinated with Pfizer. So I just want to be upfront and honest, since this is all parents on this call. Now, as far as masking around people who are unvaccinated, obviously people are tired of masks, but I want people to, if they're not comfortable not being masked, then people should continue to wear masks. Before COVID, you did not see people masking in the United States. You saw people masking in other countries routinely when they were out in public, but that was not the culture here in the United States. Now that COVID has happened, some people may not believe what my experience is with the vaccine. They may not trust what I'm saying about the vaccine. And if you want to still wear your mask, please wear your mask. I think that they are effective, and I think that you have that right to do that. But if I'm out with somebody and I'm having coffee someplace and they're not sick, I'm not going to mask. I trust my vaccine. I'm not going to violate their social distance. I'm not going to be like in Seinfeld, be a close talker and get right up in their grill. I'm going to keep, and again, I don't think we need to keep 6 feet, but I'm going to keep my space. But if they're sick, I'm going to probably not meet with them. Or if you're doing something and you're stuck by somebody who is sick, again, these masks have not just protected people from COVID. We have had 0 cases of influenza that I know of, and I look at that stuff all the time here at Miami Valley Hospital. The number of cases of influenza in the United States are like almost undetectable compared to what we normally see. And that is because of the masking. This winter, I have not seen patients with a virus called metapneumovirus. I have not seen patients with respiratory syncytial virus. I have not seen parainfluenza because of the masking. So if you're comfortable, wear a mask. If you're around somebody who is sick, if you have to go see grandma and grandpa, if you have to go see somebody and they are sick, you know what? Wear a mask. If you are sick, even if you're vaccinated, stay home. Again, I have been Mr. Stubborn over the years of working no matter how bad I felt, and I need to change that. We all need to change that, and not just from work, but just different things. So if you are around somebody sick, it's probably not a bad idea. If you can't cancel that meeting, if you can't stay away from them, at that point, mask, but it's probably not for COVID. You want to make sure, again, our flu shots are not as effective. Other viruses we don't have vaccines for. So those type of things has made a really big impact this winter, this spring in our folks. And again, if you're not comfortable, wear a mask. But in general, everybody's healthy. If you're vaccinated, you don't need to worry about it.
Thank you. I really appreciate that, because there is a lot of personal choice here, whether you're vaccinated, unvaccinated, whether you want to wear your mask. Just wearing your mask doesn't indicate what choice you have made. And so really, I think the culture is changing, and there's a lot of benefit to continuing to wear the mask or choosing not to. So I appreciate, especially on campus, we're a very inclusive campus and really wanting to create a culture where everybody is accepted and there's no judgment if you choose to wear a mask. So I do appreciate that. I've been out and about as the mask mandates are starting to decrease. And you kind of have that moment where, do I wear it? Do I not? So I appreciate that response. I do have another question, Dr. Colon, for you. Will there be a need for a booster with this vaccine?
This is another question that comes up. There are two reasons for us to need boosters. The first one is we have a drop in our immunity, and it's time to remind our body of the immunity for a disease that we don't see very often. A great example of this is our tetanus or Tdap boosters. We need those every 10 years. And there are some conditions where that may have to happen at different time frames, different exposures. But that's probably the most common thing that we talk about. The other is when there is a change in something for what you're trying to protect. So with the variants that we are seeing right now, if all of a sudden we started seeing a different circulating variant in higher amounts, we may want to give somebody either across the population or a defined population a boost in the immunity to recognize a particular variant if we're seeing that there's a concern with immunity. Everyone, regardless of how healthy their immune system is, will see a drop in immunity from almost every disease that they get exposed to, unless there is ongoing disease exposure. That's a normal phenomenon. And the speed at which that drops depends on the disease itself and the host, the body. If we have different disorders that don't allow our body to remember that immunity or don't allow us to mount a very high response. A lot of the vaccination schedules that we have take into account special groups of people, transplant patients, patients with renal disease, patients with HIV, where they may need some vaccinations for boosters at different times than everybody else. We don't yet know for COVID what the booster schedule is going to look like, but it does appear that if we are going to continue to be dealing with COVID beyond this year, we are likely to, around the 1 year time frame or just after that, be needing to consider a booster. That may not occur for everybody because everybody has different time frames where they got vaccinated, and it may occur sooner for people who have a weakened immune system or who are beyond a certain age. We don't have that information yet because we are just now starting to see enough people long after the COVID vaccines have been administered to see at what rate is that immunity dropping? What ages do we see that occurring differently? We are likely sometime this summer going to have more clarity around that issue, but that's where the booster phenomenon comes in. It doesn't have anything to do with the vaccine not working. It's just something that happens to our immunity in almost every situation.
Great, thank you, very helpful. So I'm just going to switch gears just a little bit here for a moment. As I mentioned, we've received a lot of non-medical questions, and although the focus of this with the medical panel is really medical related questions, but I did want to touch on a few of these since we did receive so many. So I'm going to start and I'll respond to these. How will the university handle people who choose not to or cannot be vaccinated? And so how we plan on handling this is really from a public health standpoint. We are anticipating that we will do the entry testing for the non-vaccinated as they come onto campus. And then we will have, because they are at greater risk of contracting the COVID-19 virus. And really it is, like I said, from a public health standpoint to protect them as well as the opportunity to infect others. So for unvaccinated students, there's likely going to be an ongoing surveillance testing program as well. And what we'll do is we'll monitor the positivity rate on campus and around the surrounding community. And so really depending on that positivity rate is how we're going to model the testing program and protocols. And we'll look to this medical panel to really help guide us on that. Another thing that might be a little, that will be the same for unvaccinated that it has been throughout the pandemic is that if they are exposed to a close contact, somebody that has tested positive for COVID, they would be required to quarantine. And the other thing would be in some cases for travel with the CDC guidance, and depending on the travel, there may be some required quarantine upon return from travel as well. So really, those are the things that were to protect the community and those individuals that either choose to or are unable to receive the vaccine, that we would keep that program in place. So another question we're getting is, will the university mandate the COVID-19 vaccine? And so we are not mandating the vaccine. We're not requiring it. The approach the university has taken is to highly encourage the vaccine with the expectation that 70% of the entire community will be vaccinated. We're very optimistic that we'll reach this goal, and we do not currently have plans to require the vaccine. But we do believe that individuals many will choose to want to return to normal campus life. And our hope is that people will see the benefit of being vaccinated. And after hearing the panel tonight, that really the effectiveness of the vaccine and the low risk, that individuals will recognize that each member of the UD community who gets the vaccine really protects countless others. Let's see, I have another one here. When will the university relax its protocols? How will the university decide what protocols will be in effect in the fall? And does the university know what restrictions it will lift in the fall? So our goal really is to relax many, if not most, protocols when we reach that goal of 70% of the community vaccinated. We will continue to consult our medical panel and public health state and Montgomery County as we monitor internal and external factors, and we will maintain flexibility to adjust our approach and protocols accordingly. But really our hope is that we will start to get closer to that 70% and really start to see the ability to relax many of the protocols that are in place. I'm going to ask another medically related question. This one I'm going to ask for Dr. Buchwalder. An equal challenge for students has been mental health and adaptation to pandemic restrictions. How can the university prioritize a response to this? How can faculty and staff look for signs of mental health concerns?
Yes, thanks, Robin. And honestly, what you talk about going back to closer to normalcy, yes, this year has been so challenging, not just for students, but for people across the world. The isolation that has come from and fear has compounded what has already been a crisis in mental health for a lot of people and our young adults. So I work in the Student Health Center, and we do care for a lot of students with mental health problems. We work in very close contact with our counseling center, which is right upstairs from us, into supporting a lot of these students. Prior to the pandemic, the university had prioritized mental health care awareness by faculty and staff. What do I do with a student who might be struggling? And had put together some materials to help faculty and staff see the many various avenues we have on campus, ways that they can help get a student to the help they need. And even just what kind of question should I ask? So everyone on campus received a folder with a stepped care model of mental health that we've embraced here at the university. And hopefully that can be helpful to faculty and staff and our students, obviously, in getting them help they need. Encouraging students, so parents, if you feel like something's amiss with your son or daughter, encourage them either to come to talk to someone, to talk to their RA, to make an appointment at the counseling center for an intake, to if they're not sleeping well, they feel tired, they just have more kind of generic symptoms, to call the health center and make an appointment to meet with one of our physicians to really get a full assessment as to why they don't feel right. And certainly if we see a mental health issue, we will get them to the proper care, whether that's counseling, medication, and we prescribe if that's indicated. So, I mean, some of these were in place before. The pandemic certainly has caused great challenge to our students. And for our rising sophomores, the students that are coming back after a very strange freshman year, for them, college is going to be a different experience if things are more normal. They've not had the opportunity to have a normal first year experience and get to know colleagues in clubs and such. So obviously it's something I'm pretty passionate about too. I think it's really important. The university had prioritized this before the pandemic. There's a lot of work being done in our health and well-being units to make sure that folks across campus are aware. So we hope that, we have processes in place, and we hope that our students take advantage of it. And then those who are concerned, encourage the students to reach out.
And if I could just dovetail off of that, I will just say from the medical panel standpoint, the mental health side of COVID has been on my radar since day one. Things that I've seen in my personal life, things that I've seen people deal with. So when I'm making decisions, or when I'm asked about decisions or protocols or policies when it comes to COVID, yes, I think medically, but I promise you, I am thinking about the mental health aspect and trying to, sometimes it's a balance. Sometimes you can't get both to balance together. But I will tell you that at least from my standpoint, when I'm making decisions, I'm very conscientious of that because for young people that are otherwise healthy, their chances of dying from COVID are very small, but again, the suicide rates have gone up dramatically in the last year. So it's just really trying to walk that fine line. And that is something that we think about.
Thank you. I appreciate that. And being somebody that's worked with the medical panel, I can certainly attest to that. And the resources that the university has really top of mind for us. So and I have another question here that I will take. What level is our campus vaccination at the campus vaccination presently? So currently we're hovering at around 33%. So obviously that's pretty low right now. I'm pretty confident that we have more people that have either received the first dose, and there's a time lag between the second dose and they haven't uploaded their information. Or as Mary said, there might be a few people that have procrastinated a little bit to get that information into the system. So I hope that after hearing the presentation tonight as a reminder to upload the vaccine card. On the top of every university webpage, there is a yellow panel that does have report a vaccine, and you can simply click that and upload that vaccine card. That information does go, it is reviewed by the medical team, and that way, we are really looking at keeping people's information confidentially. Mary, it looks like you wanted to jump in and say something.
I was just going to say, for the regular health requirements like MMR, measles, mumps, rubella vaccine, of our first year incoming class, we've only had about 10% submit those. So we know there's a lot of students that still need to get their COVID vaccine information uploaded and their regular health requirements. So parents of first year students out there, get on the stick with them, get them uploading.
I'm going to ask this question, whoever wants to take it, is what if I have misplaced my vaccine card? So
wherever you got your card, we're asking people to upload a picture of their card. And wherever, if you were vaccinated at your local public health department or a pharmacy or another health system like Premier here in town, They keep a record of that, so reach out to where you got it to see if you can get confirmation of your vaccine dates. If for whatever reason you really can't get that for people in Ohio, we have access to the state immunization registry. It's a lot more cumbersome to try to access that information, but go ahead and open up a ticket and say, you know, I've tried this and this and this, and I did get vaccinated, and these are my dates, and we will follow up on that to verify it.
Great, thank you. Yeah, it shouldn't prevent somebody from trying to fill out that information. And as I did mention, we do have a medical team that is looking at those. And so if the card is not attached, they will reach out. So even if you have uploaded it and you have some concerns whether it was received, if there's any questions, somebody from that medical team will reach out and verify. So looks like that is all of the medical questions. There were several other questions that we haven't had time to respond to, but I would also mention that on that bar across the top of each UD webpage, we will start to post on June 1st that what the vaccine percentage is. So encourage you to go to that webpage, go to the dashboard. You'll see where we are in the level of vaccinations in the community. There's also a lot of really good information on there, FAQs, things like that. But if your question wasn't answered this evening, we do have the path forward at udayton.edu web or email. You can always email the path forward at udayton.edu, and we do have a team that is reviewing those, and we'll make sure that the appropriate person receives the question and can respond. So I really want to thank the doctors here today, and Dr. Buchwalder, Burdette, and Colon. Really great information, and your commitment to the university and the students has just been outstanding this year, and can't thank you enough. Really, hopefully you've gleaned that vaccination is really important and an effective tool for us to be able to return to normal campus life. And so really that build immunity in our community, it means our community means a lot to us. And so really pulling together so that this fall we can gather on our porches, residence halls, dining halls, and throughout campus in that UD tradition. So like I said, we will begin reporting on June 1st and really monitoring the protocols and start communicating around those starting in July. So this is really going to help us shape what the fall semester looks like. So with that, I really want to thank you for your time and your participation today. So thank you very much.